Good morning, good afternoon, all around the world. My name is Antonia Testa, and here we are for our webinar on safety challenging in this COVID-19 pandemic situation. Since the first case of COVID-19 was confirmed in Wuhan last December, the world has been through challenging times. As we step cautiously into new stages of semi-normalcy, at least in Italy, I consider it important to stop and reflect on the actions and lessons learned from this situation, especially in the context of developing countries. And I would like to thank CeSI, Centro de Ateneo per la Solidarietà Internazionale dell'Università Cattolica, for giving me this opportunity. Our discussion today will be enriched by the presence of a distinguished person who plays an essential role in our community and whose contribution has touched thousands of lives. May I have the presentation, please? This person is Kezevino Aram. Right? Okay, but who is Dr. Kezevino Aram? I had the possibility to spend a few days in Vino's house, and I could personally experience the atmosphere of the Shanti Ashram, and I could see with my eyes the numerous fruits of their work. She is the president of Shanti Ashram, a development organization she has been leading since 2014. She works on education, poverty alleviation, healthcare, especially for children, environment, leadership training for women and youth, interfaith collaboration, and women entrepreneurship. She collaborates with governments, economic institutions, interfaith organizations. Shanti Ashram community work impacts more than 250,000 people in Coimbatore, in India. Thanks to her staff, to her job, so many children have been vaccinated, and they every day welcome hundreds of children with their families. Every month, she brings together people affected by HIV, especially women, to support them, to educate them. This is Dr. Kezevino Aram. At this point, after presenting our guests, let us take a step back and go to where it all began. On December, the Chinese government website announced the detection of the pneumonia of unknown cause in the area of Wuhan, an industrial city of 11 million people. At that time, no one would have imagined that was about to happen over the next 6 unprecedented months. Italy was among the first countries to face COVID-19, with the first confirmed cases in January and the first deaths in February. It was interesting because while often in the past it was us that used to call developing countries to help them, to ask for their necessities and so on. This time it was them that were calling us, asking how we were doing and if we needed anything, showing a great manifestation of solidarity. We were facing the unknown, and when the situation was evolving at an incredible speed, we felt the need to do something to respond to it. In particular, I am very much involved for my profession in ultrasound, in the research of ultrasound for gynecological cancers. So, At that time, I realized that lung ultrasound examination can play an important role, plays an important role in the diagnosis of COVID-19 pneumonia, with a great advantages because it's quite easy to perform. It's quite of low cost. There is no need to move one patient to another department. It's easy to disinfect. It's repeatable over time. So I thought there are so many colleagues, gynecologists around the world already skilled on ultrasound. Why don't we learn as a gynecologist to use the technique to examine the lung so that we could be of help, at least in the emergency for our pregnant patients? So we developed a lung ultrasound task force with the obstetricians, pneumologists, anesthesiologists, and so on. And first, together with our young colleagues, we prepared a tutorial video and we published it in the journal of our international society. Then the American Journal of Obstetrics and Gynecology disclosed our experience on the first pregnant patient with the COVID-19 pneumonia. Then we developed a teaching program to teach gynecologists how to do that. We tested it on a small number of gynecologists, and then with the support of the national societies, we tested it in a large number of gynecologists. Just to give you an idea of how many networks all around the world we could use, we worked together. We decided to collaborate with another university in Trento with the physics engineers, and we collected video clips for the artificial intelligence analysis. And then we started a multi-center prospective international study in several countries, mainly in Europe. The virus began to spread across the globe. We found this published video, which is quite impressive. You can see from January until every day we can see the spread in so many countries, and the pandemic did not spare any countries, including the less developed ones. So now it's February. This is already March. This is the end of March and the beginning of April. We can say very, very impressive. At this point, our thoughts were again for the developing countries, because the question was, would they be able to deal with the situation, considering the context in which COVID-19 would spread in these countries? We know they already had to face so many challenges, a weaker health systems with the lower numbers of professionals and hospital beds, lack of access to health services, crowded households, with the problem because they are dependent on important medical pharmaceutical products, problem for the cross-border restrictions, in other terms, so many and more economical, political, and social problems. At that point, we felt again the need to do something for these countries, but what we could do. We tried to be in contact with some colleagues in African countries, so we could reach, with the help of CeSI office, we could reach and we could involve 12 African countries. We planned 2 seminars at the beginning of May, and it was really interesting because with about 50 colleagues in those countries, we could share our experience with some theoretical and practical aspects. This is our small contribution. I would say a small drop in the ocean. But while preparing this webinar, I was very interested. I had a sort of a curiosity, because we know that the pandemic has mobilized many organizations around the world. So my curiosity was, these organizations like universities, scientific communities, international organizations, NGO, volunteers, I wanted to know if they were able to put in practice something, what they could do to face the pandemic. So that's why we explored the literature and the official website of this organization. And now I'm going to show you only a few slides. Then after my presentation, we will ask Dr. Aram, one of the protagonists on the territory, what is her experience and if they have been reached by these strategic plans of these world organizations. For instance, it's quite impressive to look in PubMed the number of publications on one specific item, COVID-19, in such a short time period, more than 30,000. Thus demonstrating that there is the possibility and there is the desire to share the knowledge all around the world. United Nations, through their strategies, they could reach 155 million children, helping them with their learning. They could reach 1.9 million health and community workers, and they helped 28 million people with the critical water, sanitation and hygiene supplies in their global humanitarian response plan. WHO claimed the COVID-19 as a pandemic on 11th of March. Since then, they prepared strategies to contribute to help countries in the preparedness and response plan. For instance, they could reach 135 countries providing PPE or strengthening laboratory capacity. All these matters together with organizations like Red Cross, International Organization for Migration, etc. And they launched the COVID Solidarity Response Fund and the Solidarity Trial. Many other programs have been planned and been run by UNICEF or regarding food and nutrition by FAO. What about NGOs and volunteers? It's almost impossible to summarize, to calculate the amount of solidarity, the amount of work they provided in many countries. So, after this very, very quick scenario of the global action of this organization, it's the moment to dialogue with Dr. Aram. And I prepared these 4 questions for you, Dr. Vino for our friends. In your experience, during this emergency, which were the strengths of your organization that made possible the continuation of your social and health projects? And then, which were the most challenges that you faced during this pandemic and the weaknesses of the system? Then, we would like to ask you on which aspect, in your opinion, would be important to work in the future in order to improve our organizations, to face an eventual, a possible new emergency? And the last question is, if you had, as you have, because we know that you have, but if you had the power to take decisions for world organization, which strategies would you suggest to follow, to put in practice? Please, Vino, now we are going to listen to you.
Thank you so much, Antonia. Those are big questions, and those are questions I think that we will have to continue to ask us, not just during the COVID pandemic, but also going forward. I will try and connect to these questions, and I'm very grateful to you that you gave a setting in which you presented the healthcare community and how we are working. Like you said, papers, presentations, interactions are all an expression of the willingness to work together, because this pandemic is like no other. And therefore, may I request for help for the slides. The slides will help me take this dialogue forward. I live in India, and I went to medical school in India. I trained to be a doctor in India. And when I was training as a doctor, both in my undergraduate program and my postgraduate program, I had never, ever imagined an image like this, where young people of every age, from every religion, were wearing masks. As I was trained as a doctor, often this image was limited to the infectious disease room or the operating theater or certain situations. It has become a population-based, a community-based practice. I had never, ever imagined this as a young doctor. If we could go to the next image, and this links to what you said, Antonia, we could have never imagined that in modern times, 1.5 billion children around the world would have had to step out of school and stay at home. This, again, is something so unprecedented. And in my presentation, I will touch as to what this means for children, this disruption of daily life, but also the disruption of services that come with the beautiful institution of school for many children. So I could have never imagined this. And I'm sure those of you who are with us this afternoon, you will also take a few seconds to see what were the new images that you had seen in the last 100 days and more, and what are the images that continue to stimulate you to think both about the society around you, but you as a person. The next slide, please, because this is another image that I want to present to you. And this is the image in India. There will be parallels of this image in every nation. You, Antonia, are in Italy, and this image could be represented in the form of a group of older people. In India, for us, our consciousness was struck. We were shaken to see how many fellow Indians, brothers and sisters, were working as migrant workers in different parts of the country. In the image of the other, I found myself as a physician, as a leader, as a volunteer, and as an important member of the community. This also is something that I have not experienced before. The constant presentation of images of others in our living rooms, in our cell phones, in our television sets. With these three images, I want to move on to what I want to share. But hold on to these images, because each of these images speak 1,000 words. My first thought this afternoon, therefore, in the next slide would be, where does India fit into this picture? When I speak of the work of my organization, I want to speak about my country. Antonia, you beautifully showed us that world map and how the virus traveled. We are part of a large picture, a big picture, but we have to make sense of it. And for us in India yesterday, we hit 1 million patients with COVID-19. When I first started writing my academic papers in March, it was only 500,000 people around the world. Twice that number has been achieved just in my country. And the Johns Hopkins dashboard, which has become part of global vocabulary today, shows that there are about 13 million people infected with this virus. These images all speak to us about three things: the scale of the problem, the nature of this virus and how it has become a pandemic that covers the entire world, and that this has come at a high cost to the world. And in these costs, we also find the relevance of our professional training, the relevance of our work, the relevance of our mental state, and the relevance of not giving up till everybody comes under what I call an acceptable social safety net. If we may move to the next picture, next slide, I'd like to bring to your notice the hero of the story, the coronavirus. Many of us who are students of science know that it's only a few months, and in these few months, science and scientists have done so much. They've identified the virus, they've sequenced it, they've described it, they've even shown how some medicines affect this virus. It is a pace that we have not seen in modern times in terms of scientific activity. But we also know, World Health Organization tells us, that they are very non-specific symptoms. You feel like a cold and a cough. It could be any time. In Europe, in the fall, in India, during the monsoon season, you could have these non-specific symptoms. Even more dramatic for me has been that the interventions that go into disrupting of the spread of the epidemic or the pandemic has not changed. In January and February, we were beginning to write about it. In March, we were more confident about using this as public health messaging, which is wearing masks, physical distancing, not social distancing, physical distancing, and also washing your hands. The gold standard remains the same. All countries of the world, whether developed or not developed, that's the gold standard. That's what we have as proven response till now. We are working on medicines, we are working on vaccines, but as of now, that's the gold standard. And that's a big story, because this story has unified the world, the global north and the global south, the developing and the developed, the old and the new. But if I may go to the next slide, I wanted to use this opportunity of talking to you to look at the story behind the numbers. All those of us who work in medicine and in public health, epidemiology at the end of the day is storytelling. It's describing a situation. And here I think there is something for us to take away, Antonia. When we in India were watching the television reports from Italy, we began to see endless pictures of the elderly, elder men and elder women entering the hospitals, unwell in their homes. This demographic has changed. In India now, 1/4 are children below 18 years of age, 1/4 are the elderly above 60, but 50% are in the most active age group. So this demographic, which initially was considered as a problem that had huge impact on the old, has changed in terms of presentation and as we gather evidence around the world. We do know initially we thought it affected men, but now we know men and women are equally affected. It's the quality of your lungs and your comorbidities that also impact along with gender. We also know that it's not equal. The pandemic and the virus has affected those who were already marginalized, who were already carrying the burden of poverty. And this is why I think the story behind the numbers, Antonia, is part of the answer to what you asked me. And that is, what should we do in the future? The future will be better if we pay attention to these situations that make people more at risk to this virus. If we may move from the story to something more, in the next slide, I would like to describe to you is the theme of this dialogue. I really like the idea of being safe, because in the pandemic today, we can't use the word cure, we can't use the word active disruptors. All we can keep as center stage of our public health messaging and our work is be safe. And being safe is the greatest contribution that individual citizens and communities together in developing and developed countries can do in order that this pandemic slows down, and hopefully we can find a grip to it and it doesn't continue at the same pace and the same scale. Antonia, you asked me, and I'm going to pause here, what was my experience as a leader within the organization? I also had the honor to bring forth my public health skills and my medical training with the government, with the state government. My mandate was to look at the social protection schemes for children. And this was, I think, for me, a very, very constructive collaboration with the government, because we all know when you work with the government and when policy changes is brought forth, millions of children, and those of you who are watching this dialogue from around the world should know that India has the blessing, the grace of having one of the greatest numbers of children. And therefore, this work with the government highlighted to me again the power of collective thinking and the power of policy. But of course, Antonia, like you said, when the UN, when WHO, when the big organizations make policy, it should trickle down. It should find its way to the last and the least within communities. But you know what happened during this? Because of the disruption, the lockdowns that we put forth in country after country after country to slow down the spread of the virus, our normal channels of communication and implementation got disrupted at once. In India, it was at the end of a week that the Prime Minister announced, and on a Monday we started. On the 25th of March, we started the national lockdown. And this is where, Antonia, one of the experiences that has been most powerful for me has come alive. Many of us are global professionals and we work across the world, but we also belong to communities. And our expertise, our leadership, our commitment could surface, could serve our own communities. And so the experience that has been most powerful for me has been the power of the local community. As much as I speak about global institutions, I have told this pandemic has been a point of correction so that we value the local community as much as we value the global community. Somehow this pandemic has reminded us about what it is to be a good and contributing member of a local community. And I will detail in the next slides, in the lessons learned, how the idea of a community, the power of a community, and the connectivity of a community helps. The first lesson that I want to speak about as a healthcare provider and a public health professional are the frameworks that we give unto ourselves in health emergencies. There was great alignment in a very short period, just like the scientists worked on the virus, the national responses and the global responses came together. There was alignment. We were able to present to people around the world a collective dialogue, but also a collective mandate and direction in terms of how we would go forward and respond to the pandemic. I also think as healthcare providers, it was a great time to go back to basics, things that we don't often think about while we do the big things with AI, artificial intelligence, with technology, basic things, wearing a mask, washing your hands, all these things. I think there has been, again, a redistribution of attention to basics. And this for me has been an important moment for every healthcare provider, a doctor, a nurse, a paramedical staff, a social worker, to rise to the occasion, to ask the questions. Who is at risk in my community? What is the treatment protocol? What do I bring to the care framework? And I have listed a few questions, but at the end of these questions, I have something that I want to speak about again, Antonia, in terms of the experience. For me, one of the most moving and one of the most disturbing experiences in this pandemic is how we have cared for the vulnerable. The vulnerable have cared for each other. They have cared for so many sections of the society all throughout. But when things are at this stage of emergency, sometimes we have also seen the neglect of vulnerable communities. They have been at risk in America, in India, in Italy, in Africa, everywhere. They've had to be on the front lines working. They've had to be providing services to people so that others may continue with a decent quality of life. So again, the word vulnerable, Antonia, is something just like local communities has come up in capital letters to me, that not just during the pandemic, but the vulnerability came before the pandemic, and if we don't correct our policies and care for one another, this vulnerability may continue after the pandemic as well. So the first lesson is back to basics in healthcare communities and in public health frameworks. There is great value to do that. We all know how to do it. And I think it was very, very valuable to see how we quickly went back to basics, that we were able to communicate it to the community. Shanti Ashram and the International Center for Child and Public Health continues to do it. We are in the midst of a lockdown still, Antonia. Every week, relentlessly, we have continued with the public health messaging and working with fellow doctors. The next lesson is equally precious for me, and I will ask the slides to move, and that is partnering local communities. You know, Government of India announced that they would help the most vulnerable families and people living in poverty with a direct benefit transfer, which came as money to these communities. But how do you do that? On one hand, you need a technology so that the banking system could be used, but you also needed people in the communities. At Shanti Ashram, we have 90 rural women entrepreneurs who function as small enterprises, as small units. They became the last mile connectors. They brought the precious resources and the policies of the government to their community. They knew how to prioritize. They knew how to communicate. They knew how to adapt quickly to technology. So if I may request all the professionals who have joined us this afternoon, medical students, public health professionals, anybody who wants to know more about the pandemic, one of the things that I would like you to do is to look at this lesson too, which is, as much as you connect and collaborate globally, don't forget to do the same things in your local communities. Don't forget to become a responsible member in your local community. And when you do that, you go back again to the theoretical backing that we have, which is who carries the greatest burden within a community. You know, Antonia, you and I know as doctors, we were taught the life cycle approach from birth to death and death to birth. Students of genetics know epigenetics has a major role to play now in the life quality of a child. We know nature, but we also know nurture plays it. In this life cycle approach, again, we know that there are many intersections between poverty, powerlessness, disease, and vulnerability. And Antonia, my experience has been wherever these intersections have been more, we've had more mortality. When people have been poor, they have not had a voice, they've been poorly serviced by healthcare services, and they've carried the burden of vulnerability for 2 or 3 or 4 generations. There has been the greatest mortalities and the greatest morbidities. So there is a lesson to learn, not only to work with local communities, but to care for local communities so that we don't carry forward these vulnerabilities with us. I will maybe take a second here to say, you know, in the first lockdown, every institution in the country had to be closed. For many of us, this was a moment to find, ourselves and to work in the midst of all these disruptions. But in the middle of this lockdown, a 14-year-old girl and her mother walked 6 kilometers to Shanti Ashram. And we got a call from the security personnel saying there was a mother and a daughter. As soon as he said mother and daughter, I said, please ask what they want and we will be able to talk on the phone. You know what it was? This mother and daughter walked because they knew their incomes would be disrupted. They walked to make a request for an academic scholarship. Antonia, this is how deep the impact of the pandemic has been. And powerlessness, poverty, disease, and vulnerability are often close friends and cousins. We need to break it. Not just the big results in the laboratories, the great impacts in community is a lesson for us to take forward so that we can shape it better. And this takes me to the third lesson, which is also very close to my heart. And if the slide moves on, I can share that with you. And that is making sense of the big picture. You know, our television sets and technology keeps pumping us with so many different dimensions. Antonia, you mentioned 30,000 papers that are there in the PubMed. You know, every single dimension is worth it. But sometimes as a leader, as a public health leader, as a healthcare professional, as a government official, you only have so much resources. You have to prioritize. You have to see what you can do best. And for us at Shanti Ashram, we did that in the first 2 weeks with the heads of our program divisions. We quickly said, all these are the areas of concern, but let us take the areas where we can make a difference. And therefore, our priority became children and vulnerable children. Our second priority was hunger and food security. You know, Antonia, in India, my parents' generation spoke about hunger a lot. I do know endemic hunger is there. But during the pandemic, we heard the word hunger over and over and over again. The young generation, less than 18 years old, could not fathom this as to how this word was coming. We also made it a priority for us because the health systems are stretched in India. The hospitals are full, the public health people are full. We're getting the private sector in, we're getting social workers in. We still don't have enough people. We're 1 billion people. And so we decided at Shanti Ashram that public health outreach is something that we want to continue. So, Antonia, I think in this experience, there's also the discovery of what you can do well. And we did that. And in that way, we were not only players in the local community, you know, the 250,000 people we serve, but we also became a partner of a larger response. We are of the few institutions which has done such deep and extensive work for children. We've generated papers, we've generated experiences, we've generated new models of working when physical distancing is there, and in vulnerable communities, parents have had to go back to work. Children are at home. What are the new hybrid models in which we can engage children? So making sense of the big picture, not to be overwhelmed, but to be able to make sense and to do what we can do well. No dilution in quality, no dilution in focus, but to do what we can do well. And if each of us do that, it's like a big puzzle. The picture comes together. You know, on this slide, you see the little children who have become our partners. Through them, we have started doing public health messaging in the families. This is a group of children less than 10 years old who were part of a workshop of creating education in their own community. So I'll move to the fourth lesson, and if you may move the slide, which will be, I think, again, equally important for me as someone. We're quickly getting to the next slide.
Next slide.
Is this image? Many of you will know this. You would have learned it in your classrooms when you had your public health sessions. You would have seen it in other situations as well. This is called the socio-epidemiological approach, which is where you place the child or anybody you take at the center and create the circles around it of influence. And for me, Antonia, this has also been a wonderful moment to retrieve all the theoretical reservoir we have of knowledge and to quickly adapt it and customize it for the response. The socio-epidemiological approach is basically looking at all the influencers in a child's life. The child's family, the community, the organization, the government. You can replace these names. But this socio-epidemiological approach is how we responded to the community, Antonia. And we've been requesting the government and other institutions to look at it so that there is a logical lining up of actors, and the child who is at the recipient of our services gets the best organized and the best services that is needed by the child. So the socio-epidemiological approach is another lesson that came alive for us during the work. And I'm coming to the last 3 or 4 slides, but if you move to the next slide, I think the other important lesson that we took away is not to lose sight of the scale of the problem. You know, Antonia has seen the slide before. As you know, this is on the left, you see all the states of India, and on the right, you see countries of India. That's the scale. And I'm not speaking of it just in terms of data, in terms of how many children we have and what should be the scale of our response, but also in terms of mental preparation. I keep telling my team, every time I'm working with the government, I keep telling them, are we ready for a marathon? It's not a sprint that we are preparing ourselves, but for a marathon. And when you prepare for a marathon, you have to prepare the body, the mind, and the community together. And therefore, I think one of the lessons learned is the preparation in multiple dimensions. If you move to the next slide, please, I'm going to present something more in a continuation is, you know, one key takeaway for me, Antonia, and this is probably in the way that I look both to the present and the future, Antonia, is you must do what you should be doing. Don't back off. The country needs you, the community needs you, the world needs you. Do what you can do. If you're a social worker, do that. If you're a nurse, do that. If you're a doctor, do that. Dr. Antonia Testa just showed us how she and her team worked on using the sonological methods in responding at these times. Do what you're doing and do it well. The principle of comparative advantage is extremely important, because when you do that, the quality of response stands out for everybody. Now, if I move on to the concluding slides of my presentation, and this will touch upon the two things that Antonia, you had mentioned about what has it meant for me. And it has meant a tremendous, I think, acknowledgement that when the problem is of this scale, we have to work together. You know, one of my colleagues used to say, what we can do together, we must never do alone. And during this pandemic, I have thought of the principle of complementarity, how important my nurse is, my field staff are in bringing the service to the child. How important it is for people like us to be able to actively contributing to the policies of the government. The great lesson of Buddha, who lived in this part of the world, Buddha often said, Gautama Buddha said, when you point a finger to the other, there are three fingers asking you, are you doing something? So the principle of complementarity, not only to do what we do well, but to be able to complement in the response is something that's very important. I think it's also important to be proactive. So it requires a lot of thinking on the feet. I'm sure you in Italy have been doing it, not to be overwhelmed by just the present, but I think be charged with what you can do for the future. You know, children may not go back to school in India till October and November. So we're already thinking in terms of what do we do for children in the next 2 quarters. It's also a time to bring back the power of solidarity. Before the pandemic, these words were casually used, unity, solidarity. I think everybody has been reminded of the power of solidarity and of human unity. I hope we will be able to remember these words even when we're out of the pandemic, that together we are safer, together we are happier, together we can do more. The individualistic way of living has come with a cost. It may not be directly to COVID-19, but we see how many people have lost their mental strength and lost their lives. Suicides and mental health problems have gone up significantly. And it's not because of the virus directly, but by the indirect consequences of what this has meant in the lives of people. So proactive public health outreach, messaging that is significant and people-friendly, information sharing, because the world is really a global resource today. And do not forget, for every word that you say should be done, there is a call to you to do something concrete. Concrete action, global and local, are both valuable. It's not one without the other. They have to be together. And so I think when I think of this pandemic, I also think of the recalibration of so many things: the global, the local, the individual, the collective, the government, the community, the scientist, and the social worker. But also, I think an important part of this has been the spirit, the message of solidarity. And many of our faith traditions have taught us that unity is not just a word, it has to be an internal experience of wanting to live together. When you want to live together, mutual respect and mutual care and good quality care comes into play. But let me then come to the very final 2 slides that I want to present to you. This is so basic. Many of you who are medical students would have heard this in the first day of medical school, you know. Health is a state of physical, mental, spiritual, and social well-being. This pandemic, Antonia, for me, has brought out all the 4 pillars of health. The physical dimension we spoke about, the social dimension, the physical distancing, the community messaging, the mental dimension. We're doing a lot of work at Shanti Ashram and the Center for Child and Public Health with adolescents on mental health, because we have seen suicides have gone up, anxiety, anger, so many of these emotional burdens, emotions have been accelerated and augmented during the lockdown because of the indirect consequences. So this basic definition of health, I think, has been driven back to us, that in normal times, whatever is the new normal, we must not forget that if we want to be healthy, all these 4 pillars have to be nurtured. And the composite response for COVID-19, of course, will be with health, but we should remember that there are other things that can also contribute to mitigating the risk of the pandemic. The next slide, please. And I'm going to end with this, Antonia, and I hope I've answered some of your questions. I, as someone who has had a leadership role both in India as well as worldwide with the organizations that I serve, the collaborations with WHO and UNICEF, and within my own organizations, have found great strength in generating hope with young people. One of the big blessings of the lockdown has been that in my busy office hours of 8-10 hours, I have devoted 1 hour to actively work with children. Every day I work for about 90 minutes, 1.5 hours, designing programs, sounding programs, implementing programs with adolescents and young people. What a marvelous opportunity for generations to work together. And generating hope, the intangible, has been equally precious, Antonia, for me, as I have generated programs, resources, and responses to the COVID-19 pandemic. I would like to leave you with hope. I would like to leave you with the images of these young people who are learning from us today how we respond in a crisis, how our characters of strength and our strength comes through not only from science, but from society and from experience that is very, very deep. So generating hope is an equal part of the COVID-19 response. Antonia, I hope I've answered your questions, and I'm happy to take more questions as we go forward. Thank you so much for this opportunity and this opportunity to dialogue with you.
Yeah, thank you so much, Vino. There are no words to thank you, because your personal life, your experience is such a great lesson. The technicians put in the title your sentence regarding to go back to the power of solidarity. So, and then you mentioned vulnerable people. If we focus, if we work, looking at that section of our family, our community, our nations, our world, we will be successful. So I think that there is no time to answer. There are some questions, Vino, but perhaps through Laura, through CeSI's office, we can send you some questions from those who are listening to us. And time now is already done, so we have to close, unfortunately. But 1 second just to share, if it's possible. I wanted to go back to this this one. Okay, you said, did I answer your questions? For sure, because you shared with us the strengths, and only your eyes are the demonstration, which is the most important tools to support our work, our organizations. Challenges, weaknesses are so many, but what we want to do for our future, and also to give support to world organization, is, as you said, we have to do what we can do. We have to prioritize. We have to look at the vulnerable, and let's go back to the power of solidarity. So I put together this work together, and thinking of you. There is a key word, education. I want to mention, as you know, Vino, that Pope Francis launched the Global Compact on Education, so we can work together very strongly to this project, And I was really impressed how your organization could solve the problem of the gap between worldwide big organizations and the local community. So we do need credible leaders as you are, and we have to work together. We can't forget also the values of the interfaith work, the contribution of all religions. So now I'm going to close the webinar. I'm going to thank the technicians, the CeSI's office support, all young people, young students, medical doctors, all the listeners. And Vino, thanks again for joining us, and all the best for your organization, for your life. Thank you.
Thank you, Antonia. I'd like to join you also to thank the entire group that technically coordinated it. If I may just end with the words of Mahatma Gandhi, what we do today will determine our tomorrow. So let's keep working and generating hope, but also using the fruits of science to serve people.
Yeah. Take care. Be safe, Vino. Bye.
Thank you.